So, I have about 10 minutes to talk about prostate cancer. And what I did is that I just imagined that you guys are coming to my clinic and you have the 10 most important questions on your mind about prostate cancer, and I'm answering those questions. So, this is one of the biggest questions that I'm getting these days in clinic, which is prostate cancer deadly? And the answer is yes. Because we still see about 27,000 prostate cancer deaths in the United States. And there is about 5 times that number of patients who are out there who would have disease that's metastatic and they are suffering of the disease, but they are just around. And if you look at all of the causes of cancer death, prostate cancer is the second deadliest cancer in men. So it's a very important and very predominant cause of cancer death in men in the United States. Now, the question that comes with that is, well, if I have a disease that had spread outside the prostate, is there treatment for it? And the answer is also yes. There are maybe 5 or 6 therapies that are out there now for patients who have prostate cancer that had spread outside the prostate. About 6 years ago, we had one treatment. Now we are having more advances in that field of treatment, and all of those therapies are good therapies. They do alleviate the symptoms, so the bone pain, the blood in the urine, all of those changes that you see because the prostate had spread, because the cancer had spread outside the prostate, you're going to notice a big relief from these symptoms by being on one of those therapies. But like with any other therapy, you're going to have the side effects from treating that prostate cancer. So even we are treating the symptoms that are resulting from the spread of the cancer outside the prostate, any of those therapies is going to come with its own side effects. You're going to develop new symptoms just because you're being treated for prostate cancer. A lot of those patients are going to have the nausea, vomiting, and diarrhea. You're going to notice extreme weakness because many of the lines that we use for treatment of prostate cancer or hormonal therapy, where we basically ablate all the sources of male hormones. Because male hormone, the testosterone that Dr. Kohler just talked about right now, plays an important role in driving prostate cancer. So you're going to notice an extreme weakness. With that comes bone and muscle pain. A lot of our patients develop breast swelling and pain, testicular pain, impotence, depression, sleeping problems. When you get to the point where you actually need chemotherapy done for prostate cancer, where all of the hormonal therapy had failed, then because that chemotherapy also works on the bone marrow, that's the source of all the important cells in your blood, patients develop unusual bleeding, life-threatening infections, and temporary hair loss. But this is the end result of all the treatment that we have for prostate cancer that gets outside the prostate. It's true that we have all of those therapies. They all work for a certain period of time, but what happens at the end, invariably, whether you're getting the treatment, you're not getting the treatment, is that all of the patients who develop metastatic prostate cancer, they die because of the disease. And if you look at that table there, you see that the number in the group of patients who were treated with this new medication that everybody's talking about, and the other group of patients who did not receive that therapy for prostate cancer that has spread outside the prostate, the number is 0. So in both groups, within about 33 months of treatment, they all died because of prostate cancer. And as of now, all of those therapies, they do prolong survival by an average of about 4 months, but that's all what our treatment for prostate cancer outside the cancer can do. So what's the chance of curing prostate cancer? I think if we detect prostate cancer early and we treat it effectively before it gets outside the prostate, that's when we can actually cure the disease. So if the disease is outside the prostate, all what we can do for it is control it, maybe prolong your survival for about 4 months or so with a lot of side effects. But unless we catch the disease early and treat it effectively, as of now, there is no cure for metastatic prostate cancer, cancer outside the prostate. Early detection of prostate cancer is usually done by doing a test that's called PSA. I think everybody in this room is well aware of PSA because it's always on the news and everybody's talking about it, but basically it's a protein that's produced by the prostate, and it's usually in the prostate and gets excreted in the ejaculate. But what happens is that if you have an irritation and inflammation, cancer in the prostate, the barriers between the contents of the prostate and the blood are broken, and that protein gets into the blood, and then that's when the protein in the blood becomes measurable. So we do a blood test, we see what the level of the PSA is, and depending on that, we decide whether we are going to do a prostate biopsy to detect prostate cancer. Who needs to be screened for prostate cancer by doing a PSA? As of now, we have these groups of males who would highly benefit from detecting prostate cancer, from early detection of prostate cancer. African Americans have a totally different disease, totally different type of prostate cancer than everybody else. Their disease presents with higher PSA, it's more aggressive. Many of them, by the time they present with prostate cancer, their prostate cancer is already outside the prostate. And even within the prostate, the distribution where their tumors are is different from everybody else. All the studies, most of the studies that we have on prostate cancer, they were done on Caucasian males. So the results of these studies, they apply to a white male. They probably don't apply as well to an African American patient. The second group is a group of males with family history of prostate cancer. Now, I get patients in clinic, and I had a patient today who was asking me, he thought that he had a very strong family history of prostate cancer, and we said, well, what's your family history of prostate cancer? His father was diagnosed with prostate cancer at the age of 80. That's not family history of prostate cancer, okay? Family history of prostate cancer is when you come in with a father or a brother or an uncle who was diagnosed with prostate cancer at a very early age, at the age of 45, 50, that's family history of prostate cancer. Family cancer is, prostate cancer, again, is almost the most common cancer in males, so it could just happen by coincidence that you have somebody else in your family who has prostate cancer. But if it's a first-degree relative who developed prostate cancer at an early age, that's family history of prostate cancer. Why is it important? It's important because if you have that type of family history of prostate cancer, then you can have a mutation that's actually predisposing you to a more aggressive and a more severe type of prostate cancer, and it's something that you need to be aware of. And it's also important because if you have a son, your son might need to know that this thing is going on in the family so that he's on it. He knows that there is the possibility that he might develop prostate cancer, and he might seek either early detection or early treatment so that he doesn't end up with metastatic prostate cancer that we don't have good treatment for. And then finally, the last group is this group of males between the ages of 54 and 69 years of age, or otherwise healthy. And I say healthy because if, let's say you have other health issues going on, let's say you have a severe heart disease, and your life expectancy is less than 10 years, then probably treating you for prostate cancer is not going to prolong your survival that much, okay? So we get into that discussion, and if you have other health issues that are affecting your survival, then we might not even start doing the workup for an elevated PSA, but I think it's an important discussion to have. So if you're in the age group between 54 and 69, and we do the PSA checking for prostate cancer, and then you come up, then your PSA is elevated. So you're one of these groups, and your PSA is elevated, and elevated PSA for me is above 3. So what's the next step? And what I do to my patients in clinic is that if this is their first check of their PSA, I would repeat that PSA just to make sure that this is an actual elevation of their PSA. This is just not a lab error or something else going on before we start all of their workups. And then if that PSA is still elevated, the usual workup for those patients is to proceed with doing prostate biopsy. But if there is the suspicion that this PSA could be just related to an enlarged prostate, you're telling me that you're having a lot of issues with urinary symptoms, you've been on treatments for enlarged prostate, and the PSA could have just been elevated because of the enlarged prostate, then there is a new test that we're using in clinic. And what's specific about that test is that it's not affected by the size of the prostate, and it's not affected by any kind of infection, inflammation that happens into the prostate. It's a urine test. So just when we are doing the prostate exam, when we're done with the prostate exam, you give us a urine sample and we get that test. And that test is more specific for prostate cancer. If you had PSA done before, and maybe you had a biopsy done before, and you're presenting with an elevated PSA and you don't know what to do with it, then the new thing that we are doing at Southern Illinois University is doing prostate MRI. And to develop this prostate MRI, we actually worked on protocols with Memorial Sloan Kettering Cancer Center in New York. We worked with centers in Europe too, so that we can get a protocol that's very specific for prostate cancer, so that when the radiologist tells us that we think that there is a lesion in the prostate that is highly suspicious of cancer, then he's telling us or giving us that information with high confidence. So that if we say, well, let's go ahead and do a biopsy, okay, we have good information that we are working off. And then just like as I just mentioned, if you have an elevated PSA, if you have an elevated PCA3, and if you have lesions on your prostate that we are seeing on the MRI, then prostate biopsy is probably the next step, okay? And with that prostate biopsy, I'm putting targeted in between two parentheses. Since we are doing that MRI and since we are able to see those lesions, the difference that's going to happen after we've done that MRI is that we are able to actually target that lesion that we see on the MRI with the needle. So instead of the usual biopsy where you get the ultrasound and the ultrasound is just showing us which part of the prostate we are taking our tissue from, now that we have the images from the MRI, we can actually direct our needles to that area of the prostate where the lesion is. And soon we are going to have the technology where we can fuse both images so that we can put a marker on a lesion in the prostate where we say this is the lesion that we want to biopsy. And the same technology, it's called fusion technology, is going to show us a point on your ultrasound images where our needles should be so that we can better detect prostate cancer if it's in the prostate. And this is what's good about the prostate MRI. There are a lot of imaging modalities out there. People get CAT scans. They see an enlarged prostate on CAT scan and all that kind of stuff. But those other types of images, they don't give you enough details about what's going on in the prostate. Well, if you see on this picture with prostate cancer, with the MRI of the prostate cancer, you can actually see that tumor. And this is what I was getting at when I was talking about doing the targeted biopsy, because if I see that lesion there, I can just put my needles into that lesion and get the tissue that I need instead of doing a random biopsy. I might not be even hitting that lesion. I would be taking tissue from other places. Your PSA would still be high after I've done with that blinded biopsy, but I'm not going to be giving you the answer. So what the MRI doing is that it's helping us get to the answer of whether you have cancer or not in a better way. Okay. Going back to the prostate MRI, in addition to the patient that I just talked about, if you have a high PSA with a previous negative biopsy, that's where prostate MRI would be good for you. We're also using prostate MRI to those patients who want active surveillance for low-risk disease. The whole idea about doing active surveillance for low-risk prostate cancer, for the prostate cancer that has low potential of metastasizing or going outside the prostate, is that you actually, in all parts of your prostate, have low-risk disease. What we try to avoid is telling you that, okay, you have a low-risk disease, we can just watch it, but we are not actually detecting a more aggressive cancer sitting somewhere else in your prostate, okay? So that's where the MRI is good, because we are getting an image of all of the prostate. We're biopsying all of those lesions in the prostate so that at the end, we're more confident that you have a low-risk disease that we don't need to treat. And that's why we're part of our protocol. If you come in with a low-risk disease, that we do prostate MRI so that we can make sure that you don't have a more aggressive disease that needs treatment. The goal of all of these technologies, the goal of the PCA3, the goal of the prostate MRI, the goal of the targeted biopsy of the prostate is to make sure that you don't have a higher risk disease, a disease that has the potential to spread outside the prostate. In academic urology, at SIU, our target is not to treat the low-risk disease. Our target is just to make sure that you don't have a more aggressive disease that needs treatment that's going to affect your survival, okay? So if we've done all of this workup and we ended up with this type of cancer, which is called low-risk prostate cancer, which is about 60 to 70% of prostate cancer that we see in clinic, where your what's called Gleason Score, and people who've dealt with prostate cancer know what Gleason Score is, but it's basically when they look under the microscope, they look at how disorganized the cells are. And if the cells are not very disorganized, they give it a score which is called Gleason Score. It's Gleason 6. There is Gleason 7, 8, 9, and 10. But Gleason 6 is the lowest group. If your PSA is less than 10, which is the blood test that we just talked about, and your prostate cancer is just localized to a small segment of the prostate, then you have what's called low-risk prostate cancer. And for low-risk prostate cancer, we can just treat it. We don't need to do, we can just watch it. We don't need to treat it. And watching it, basically, just checking on your PSA, making sure that the PSA doesn't jump, and then every 12 to 18 months, repeating a biopsy or repeating an MRI. And as the experience with doing prostate MRIs gets better, we'll be able to substitute doing the biopsies with just doing the MRIs. It's just watching a mass that we think it's harmless, but we just want to keep it in check. So you would get the biopsy and the MRI at the beginning to make sure that this is actually a low-risk disease, and then we'll be able to just follow up on that mass with MRIs and make sure that the mass stays the same size and stays inside the prostate. Thank you.